Esparza is currently the Executive Director of the New Mexico Breastfeeding Task Force. She is a trained certified lactation counselor and community interpreter who previously served families as a breastfeeding peer counselor for more than 10 years, providing peer-to-peer support to lactating families through the WIC program both individually and in the hospital setting. She participated as a leader in the Health Connect One Birth Leadership Academy and the New Mexico Women of Color Leaders and nonprofit. She has served on different boards and currently sits on the National College of Midwifery Board and the New Mexico CNM Board. As a Mexican immigrant woman living in the South Valley of Albuquerque, she brings a grassroots community approach and an equity lens into her every aspect of her work. She understands the importance of centering families and BIPOC communities is a crucial step into achieve birth equity. She enjoys hiking and gardening with her husband and 2 children. Elizabeth Koffler is a board-certified family medicine physician. She received her medical degree from Drexel University College of Medicine in Philadelphia, Pennsylvania, and completed her family medicine residency in Lancaster General Health Family Medicine in Lancaster, PA. She is currently the Family Medicine Program Director at the UNM Santa Fe Family Medicine Residency Program. She chose to join the Santa Fe program because of the residency's commitment to caring for the underserved communities of northern New Mexico. In her role as program director, she's an attending on the inpatient teaching service and at the Family Medicine Center. Dr. Koffler has a special interest in inpatient medicine, nutrition, women's health, and outpatient procedures. She enjoys mountain biking with her husband and friends on the amazing trails, and also enjoys music, running, skiing, and being outdoors with her dog, Roxy. So with that, if you guys go ahead and bring up your slides and take it away from there.
Hello, everyone. Thank you so much for having us here and being able to share about a topic that's so important for our communities, but also so important, close and dear to my heart. As mentioned, I'm the Executive Director of the New Mexico Breastfeeding Task Force, which is a 501c3 nonprofit organization. It is a statewide lactation coalition that is working towards supporting communities to empower them and to create communities where breastfeeding or lactation is a cultural norm for infants and for children. Oh, sorry about that. And so once again, just I'm excited to present or co-present with my colleague, friend, partner, and one of our board members, Elizabeth Koffler. And we have no financial conflicts of interest to disclose. So just going to go over, review the objectives for today, and hopefully by the end of this session, you'll be able to describe the physiology of human milk production and factors that influence lactation success, identify evidence-based best practices to support postpartum parents in maintaining milk supply, and evaluate common myths and clarify current evidence related to prescription medications and their effects on human milk. We're going to be covering several different topics throughout the session. So first of all, the glossary. We're going to talk about benefits of human milk feeding, milk production. We're going to go over case studies so that you can have some hands-on practice. And we're going to talk about Medicaid and lactation care coverage. We're going to provide resources and then move on to questions. And so this is the glossary or the language use disclosure. Throughout this training, we will aim to use inclusive language such as human milk feeding, breastfeeding, chest feeding, lactation, lactating parent, birthing parent, and support partner or parent. At times, especially during case studies, we may also use the term mother, but we really encourage you to use the language that best aligns with how your patients and parents identify. Our shared goal is to ensure that every individual feels seen, heard, and cared for. So let's talk a little bit about the physical, psychological, and economical and environmental benefits of human milk feeding. I think this is a part that most of us are aware of, but there might be pieces of this that maybe are new to you or you may not be aware of. Human milk comes with a huge amount of benefits for both children, parents, the community, the economy, the environment. And so I'm going to go over like the top level ones, but there's many, many more. For infants and children, human milk feeding lowers the risk of ear and respiratory infections, diarrhea, atopic dermatitis, obesity, diabetes type 1 and 2, celiac disease, Crohn's disease, and ulcerative colitis. It also lowers the risk of asthma, SIDS, and leukemia. It lowers the risk of otis media, necrotizing enterocolitis, which is so important for preterm babies, and late onset sepsis in preterm infants. And this is all from the Academy of Pediatrics. For the parents themselves, they also get a lot of benefits from continuing their lactation journey, such as they have a decreased risk of excessive blood loss, uterine involution, hypertension, type 2 diabetes, rheumatoid arthritis, perinatal mood and anxiety disorders, or PMADs as it's widely known, cancers such as breast, ovarian, and endometrial thyroid. And just something to keep in mind that breastfed or chest-fed infants have an increased lower risk for sudden infant death syndrome than non-breastfed or chest-fed infants. It's actually a huge increase. Some societal benefits of human milk feeding. One, it saves lives in many different matters. One, in the health outcomes of infants and their families, but also during emergencies. It saves money, though that's a hit and miss. I say time is also money, and there is an investment of time for the human milk feeding parent as they invest this time into the life and the well-being of both their child and themselves. But buying formula bottles, all of that, it does save money. It saves the environment. Once again, there is less trash that is put onto the world since human milk feeding comes in its own recyclable package, which is, our bodies. It is the safest way to feed an infant during emergencies. There's no heating or reheating, or if there's a lack of water or ways to sanitize, there's no need for that, since human milk is always available at the right temperatures at the right time. And it supports improved familial health outcomes. Something that we know here in New Mexico is that New Mexico families want to breastfeed or chest feed their babies. We are actually hitting higher milestones than national average on ever breastfed. New Mexico is at 83.4% of babies being provided human milk. And what that means is that parents and families want to breastfeed or chest feed their babies. That's the intention at the start. We do see a drop off at 6 months, but as you can see, we're still higher than the national average at 62.3%. By 12 months, we continue to see that drop at 42.8%, still higher than the national average. Also understanding that if you think about the beginning of life of the infants, and as time progresses, the needs for families to go back to work or experiencing other barriers, medical barriers, lack of access to lactation support and others, we can see why that drop off happens. And that's why we're here to talk about a little bit about what your role can be in that. In exclusive breastfeeding through 3 months, we see that in New Mexico, 52.3% of families are continuing to breastfeed or chest feed their babies at 3 months exclusively. That means no additional formula or water or anything else. And then exclusive breastfeeding at 6 months is 29%, which continues to be higher than the national average. We do see we also see that it's lower than a national average, which we want it to be, but we still see a high percentage of infants receiving formula before 2 days of age at 13%. And we know that to be for many factors, such as lack of knowledge, informed care, back to work, even at that early stage, and lack of access to lactation support. So a little bit about the stages of lactation. What happens during those first couple of days and what happens throughout the rest of the lactation journey for the parent themselves. We know that there is a hormonal process during the colostrum phase that allows the body to start creating that milk that's going to feed the infant for as long as the parent is able to. The following, like during the week of the first week of life of the infant, we see a changes in the hormones, and it really does work on supply and demand. The more the infant has access to the breast and is able to nurse appropriately, the more the milk is going to get established in those first few weeks. So we want that diet of the infant and the lactating parent or mother to be as close as possible for human milk feeding to be the least interrupted as possible, as medically possible. And that includes ensuring that the parents have the support that they need, the access to the tools that they need, and knowledge of what to do when things may not be going in the right direction, so that they can continue that their lactation journey and be able to establish a good milk supply for the rest of the journey of the mother and the infant. We see here all the processes that go into human milk feeding. There is the milk ducts, the areola, the nipple. The nipple was just an anchor, really, to help the infant latch on. We call it breastfeeding, not nipple feeding, and there is a reason for that. That the infant actually latches on the whole breast itself, on the breast, as much as the breast is possible, versus just the nipple. And a lot of the times, this is the place where many parents may find they need a little bit more support in establishing that piece of it. Even though breastfeeding or chest feeding is a natural process, there is a learning curve for it, and many parents find themselves that they're learning this process just like they're learning to be a new parent. We also see that the axillary lymph nodes and the fatty tissue, the lobules, the fibrous tissues, all of these pieces inside the breast work together to create the human milk and to establish it as that diet of the parent feeding on demand, and the child actively and effectively removing the milk from the breast. And so now that you have a short synopsis of how milk is made and the importance of it, we're actually going to dive into cases so we can learn more on a daily basis how to support parents that are choosing to breastfeed or chest feed their infants. One disclosure is that these cases are adapted from real life situations, but identifiable characteristics haven't changed. The photos in these images are not the photos of the individuals from the cases. These are just examples for discussion and learning purposes. And for this, I'm going to pass it over to Dr. Koffler.
Awesome. And so, really the goal that I really want to make sure that we talk about through each of these cases is that our goal as primary care physicians really is to kind of understand what's normal, what's not normal, and knowing that less is more, and to not interrupt that dyad pair. And so the more we can assess that early and get our patients to our people who know the most. So our, our lactation counselors, our CLCs, our IBCLCs, they're the ones who can really help support us. And so, my overarching goal, this whole talk is to remind you all, referring early is the best. So case number 1. Anna comes in with her infant for a routine newborn visit with their 3-day-old infant. This is her second baby. With her first child, she stopped breastfeeding at 2 weeks due to a perceived low milk supply. She reports concern that the new baby may not be getting enough milk. She reports the following: feeding on demand, frequent feeding sessions. She states that the baby is constantly eating, plenty of wet and soiled diapers, and that the infant's initial weight loss was within normal range. And now at this appointment today, the baby has regained birth weight. So what more do you need to know? And you can put your answer in the chat, or if you want to unmute and say something, either way works. And what resources, information, or education can happen during this visit?
Yeah. My question is, what is feeding on demand? Can you specify what is feeding on demand? How many times in a day?
Can you repeat that question? I can't hear you.
She said, what's feeding on demand? Like specifically.
Like how often?
Yeah, that's a good question. So before I answer, does anybody know that answer? What does feeding on demand mean? How often does that mean?
When I have a baby, something like what you want every 2 to 3 hours they need. So that's feeding on demand pretty much. But
This is for like bottle formula, but for the breast milk, like every 30 minutes. When she needs just, you need to introduce the breast.
Seems like it means different things to different people.
Yeah, different things to different people. I feel like that's, and I really was happy that everybody had those different answers, because I think that's one of the myths as physicians, that we really want to make sure that we dispel those myths during that first office visit, because as physicians, we've been taught in many different ways of what's normal feeding. We've heard on maybe taking a test that a baby should feed every 2 to 3 hours, or maybe 2 to 4 hours, and so we learn those maybe numbers and we say it to a patient in a visit, but we want to make sure that we kind of understand whether that's even real or not. And so feeding on demand truly means on demand. So when the baby has hunger cues and is showing signs of hunger, that's when the lactating parent is going to feed their baby. So it's not necessarily a certain amount of time. Monica, do you want to comment on that a little bit more as a CLC?
Absolutely. And so, yes, so to reiterate what Dr. Elizabeth said, it is parents understanding those feeding cues. And so that's something that could be asked to the parent, right? What does feeding on demand mean to you? Or what does frequent feeding sessions mean to you? Because it is recognizing those feeding cues, feeding the baby as much as they want, as often as they want. Many of the times we also say 8 or more in 24, so that the baby has eaten at least 8 times in a 24-hour period. And that helps families have like a tangible, or even yourself as a provider, a tangible number, knowing that just like adult humans can eat at different times, infants also will tend to have moments or times of the day where they eat closer in time, and other times of the day where they might take longer breaks.
How would you as a physician respond to the parents' comment about the baby's constantly eating. It sounds like maybe she's having some worries around that. How would you word that when you talk to the patient during the visit?
Well, based on the baby's age, it's probably cluster feeding. So I would talk to the patient that this is a pretty normal thing that's happening and describe how long it would last for, and normalize it for them.
Awesome. Yeah.
And reassure them that they're like right at the right birth weight, that it's normal to have an initial weight loss.
Yeah.
And I would say objectively, the baby is getting enough milk, right, based on like weight and diapers and everything. So I'd probably like drill more into what else is mom like. Are you worried about anything else? If you feel like you're bonding well with the baby, if you feel like baby getting a good latch, or
Perfect. Yeah. And I think, thank you, Daniel. I think that really is sort of, again, like the key of this case is that you as the physician don't really need to know like all the answers to, lactation medicine, but you do need to understand how to assess the patient's worries. And so like, do they feel like things are going well, or do they feel like they're not going well? And that's where on that first visit, you can dispel some of those myths, because a lot of times, as you all know, as family docs or primary care docs, that, if you're, in the office, you're running behind, someone comes in for like their 3-day-old visit, and they regain birth weight. It's very easy for us as physicians to like make that a quote quick visit or an easy visit, right? Like, oh, they regained birth weight, like everything is well, right? But that is the key time during your visit. That's the key time when you're seeing a patient where you really want to practice that preventative medicine, where you are dispelling those myths, you are giving them that anticipatory guidance as what they might see before they come back in, so that when they do come back in for that 2-week visit, if things have gone on, in their experience with breastfeeding from 3 days to 2 weeks, they have felt the confidence that they know that they can reach out to you, or you can provide them the referral that they need to work on some of those things before you see them at 2 weeks.
I have a question. I think the feeding on demand makes sense. Like no 8 and every 24, but it doesn't necessarily have to be like every 2 to 3 hours. I guess my question is, I feel like when they're still in the hospital and like 24 hours old, I think we really harp on the parents. Like, oh, like you waited 4 or 5 hours. Like, you need to like set an alarm for every 2 to 3. Do we guide them a little different in the first 24 so baby's like more sleepy and may not like wake up for? So like establishing, or would you kind of go with the same?
Do you want to comment first?
Yes, absolutely. That's a great question. And yes, the first day of life is going to be different than the rest of the days. That is because birth, as we know, is birth, it's work. And just like the parent is tired, the infant is tired, and it takes a bit for the infant to recover. So that's why it's so important that in the first hour of birth, that first feeding that happens, that skin to skin that happens in the first hour of birth is so crucial for the infant and for the parent. Because usually after that first hour, the infant will take a good rest, will sleep a lot, will recover. And that's where sometimes that misconception or misunderstanding that the baby's supposed to be eating and it's not eating, and there's concerns about that. As long as at some point during that first day, the baby is coming back, the baby's waking up, and we're seeing that it's latching, and we're guiding the parent to learn about how to assess, ensure that the baby's not just latching well, but also taking those gulps and drinking properly. Then we kind of let that first day just be a day of learning. we teach the parents, I always teach the parents about the size of their newborn's stomach, which is the size of a little marble, which doesn't take much to fill it. I teach them about the colostrum and the importance of colostrum, how it is like the baby's first medicine because it's full of antibodies and other things that are going to help the baby support their immunity for the rest, even after the rest of their lives. So that first day is all about practice and learning how to latch and learning about how the baby is taking in the milk and guiding them and letting them know that towards the end of that first 24 hours, that baby is going to wake up and is going to want to feed very often. I heard someone say cluster feeding, that cluster feeding is going to happen. So anticipatory guidance for the parents to know that that's coming up, so that they don't feel overwhelmed. And in the question, in the concern about the parent, baby constantly eating, right? Because then there's that concern of why is this baby wanting to eat so much. Well, maybe the first day rested a lot. Now it's recovering on the second day. Hope that answers your question.
Yeah, thank you.
Should we go to the next slide? I think we hit everything there. We can go to the next slide. So the outcome for this case, upon evaluation, the infant appeared healthy with no concerns noted. Weight gain, diaper output, and feeding behaviors were all consistent with normal newborn patterns. And so the provider reviewed with the parent the following: how to assess adequate milk intake and output. And so you guys all said it very astutely about the wet diapers. Understanding normal newborn feeding behavior, including frequent feeding and cluster feeding, signs of effective latch and milk transfer, and when to seek additional support or follow-up. The provider referred the parent to a local lactation support group for ongoing guidance, reassurance, and community connection. And I just want to mention here too, no matter what, for me, when I see our newborns in the office, even if everything is going perfectly, I still give them the referrals to the local lactation groups, because you never know like what's going to happen after they leave your office. And I always want my patients to feel like empowered and prepared after they leave. So, all right. Case number 2. Rachel, a lactating parent with a 3-month-old infant whom she is exclusively breastfeeding, comes into the ER with right upper quadrant abdominal pain. Rachel undergoes a CT scan and a right upper quadrant ultrasound. The surgeon recommends a lap cholecystectomy. Rachel expresses significant concern about how imaging contrast, anesthesia, pain medications, and surgery may impact her breast milk and her ability to continue breastfeeding. What are the current recommendations for breastfeeding parents undergoing imaging with contrast and surgery? And how do you frame the discussion with the patient? And again, feel free to put it in the chat or unmute yourself. What do people know about, say, now I know for this case, if they are coming in with cholecystitis, they might not get contrast. They might just be getting an ultrasound, but let's just pretend that they got a CT with contrast. Anybody know what to do or how to educate your patient if they got contrast?
Yes, I can talk about this. I'm breastfeeding and I just had the MR with contrast yesterday, and I searched for myself too. And it's totally safe after the contrast. It's, using your body leaving your body with the kidney. But if they want to be conscious, you can recommend to pump the first breast milk or 24 hours, the first day breast milk, and discharge it if they feel it's safer for them. But otherwise, it's very safe. And I checked my daughter, nothing happened. Yeah.
Awesome.
Yeah.
I'm sorry, can you just repeat the second half of what you said about pumping? I heard the first part about you looked it up yourself, you you saw it was totally safe. And then I missed what you said about the pumping.
Even if it is safe, if they are still cautious about it, we can recommend to pump the breast milk and discharge and continue to introduce the breast after 24 hours. But it's not necessary.
Awesome. Yes. Yeah. And I think this is, again, like a very common myth for physicians that contrast would be something dangerous to breast milk, and it's not. It's totally fine. So less than 1% of IV contrast actually enters the breast milk. And because of that, if it's less than 1% in the actual breast milk, less than 1% ends up being absorbed by the infant. So it's less than essentially 0.01 in the infant, so which is like negligible. And so this is an official recommendation by the American College of Radiology that breastfeeding does not need to be interrupted with any contrast. And so I really encourage you all, when you are, in the hospital taking care of patients, to make sure, you're noting that, looking it up. It's very easy for physicians to just say, pump, because you feel like maybe they have time to look it up or something like that, but it's totally fine to do. Okay, what about surgery? What about anesthesia?
So same.
Same?
That's it.
What if they're like super drowsy and they can't even hold their baby?
Well, then no. But the anesthesia should set their system quickly enough that they'll wake up. So it's also not going to pass on your baby.
Yeah.
The point is.
Yeah, exactly. So per the American Society of Anesthesiologists, parents may breastfeed as soon as the mother is awake, stable, and alert. And so really that's all we're waiting for. So if the parent is so sleepy and out of it that they can't hold the baby, would be the only thing holding you back from that. But as soon as they're able to, they can. And what about opioids?
They said, right, like postpartum pain, we can prescribe like maybe 4 days of the hospital for, C-section or whatever. But they said that's not going to affect the baby breastfeeding for a few days.
Perfect. And you guys probably know this a lot as primary care docs or family docs that are on the OB floor a lot, that like if you're discharging someone after like a C-section or maybe having multiple babies, that you'll often send them home with a course of oxycodone or maybe hydrocodone. Does anybody know there are 2 specific opioid related medicines that should be avoided? And there's only 2. The rest are pretty relatively safe. And Monica, you can go to the next slide. So it's codeine and tramadol. Those are the 2 that you do want to avoid during breastfeeding. But for the most part, opioids are safe, and a short course is totally okay to do. And the codeine and tramadol answers there, that can sometimes come up on your board exam for your board certification. So in family medicine, so you might get like a question like that on your boards. All right.
I have a question.
Yeah.
Methadone.
Oh, good question. Methadone. Yeah. Does anybody know this answer before I answer? So according to, oh, go ahead. Somebody was going to speak.
Feel like, receiving the treatment of methadone, or we should breastfeed.
I'm sorry, repeat that one more time. I can't hear you.
That just if they are actively using while you definitely should not recommend it.
But I think UNM actually says that you can.
We can check about it.
The only like strong contraindication drug wise would be stimulants.
Yeah.
Say that one more time, Daniel. I can't quite hear everybody from the group.
They're talking about like active use of opioids.
Yep.
And generally, I think that it is okay to breastfeed as long as it's a good supply, because the big contraindication would be stimulants. So if you're getting like street heroin that might be mixed with something, that's a bad idea. But if you're like on methadone, for example, you definitely can.
Yeah, technically, so for methadone and buprenorphine, both of those medicines are not reasons to discontinue breastfeeding. And so the research shows that it's safe. I don't know if Monica, if you have anything to add about that.
Yeah, I think when we're talking about substance use parents, right? If that's the case, and that's where if they're enrolled in a program to support their discontinuity of the use, that's generally safe. Is if they're using, if it's a substance use parent who is not in a program and is having difficulty with usage, then that's where that is not safe and not recommended.
Agree. But I think, too, you know, when you're on your maternal child health rotation at UNM, they do typically, as long as the patient has good follow-up and they're enrolled in a program, they are able to continue breastfeeding on methadone and buprenorphine. So any other questions?
Slightly off topic because it's not an opioid, but still substance use. We have a lot of parents that are consuming marijuana, and I don't, and because it's fat soluble, it can concentrate in the breast milk. I think I'd be interested in just knowing what the official recommendation is, but I think in my experience, you'd recommend to stop, consuming marijuana during breastfeeding, but I'd like to hear more about that.
Yeah. That's a good question. So technically, the official guideline, I believe, and anybody speak up if I'm incorrect, the technical guideline is you are not supposed to encourage patients to breastfeed if they're using marijuana.
When I tell people like receptors in the brain that are involved in brain development, and they are.
I missed that. Was that Dr. Lax? Can you repeat that again?
Receptors in the brain. Same thing with adolescents and what they think. There's alteration of genomics and on their DNA too.
Yeah.
It's a significant concern about.
And it's tricky because we don't have, like, there's still a body of research growing, and with many of the states legalizing marijuana use, it does make it like sort of a tricky conversation with patients. But technically, according to the ACOG guidelines, you should not recommend it because there can be byproducts. So the jury is out, but I would still say no.
And I think I would add to that, as a patient advocate, that piece about there is everything you guys just talked about, the impact it can have on the developing brain of the infant, the fact that it is fat soluble, so it stays in the body longer, and it stays could stay in an infant's body longer, and the fact that we don't know, that there's a lot of research that we don't know, so that the patient themselves, it's informed consent, right, and informed decision making. They know the reasons why you are recommending not to breastfeed while using, or to stop using so that they can continue breastfeeding.
Any other questions? So Rachel was reassured and educated on current evidence-based recommendations. She learned that most contrast agents used in CT and MRI imaging are safe during lactation. Only a small amount enters the breast milk, and even less absorbed by the infant. She was also informed that breastfeeding can be safely resumed after surgery as soon as she feels awake, alert, and comfortable. To support her plan of care, Rachel chose to pump a small amount of milk to have available for her baby during the procedure. She was provided with a pump and received guidance on milk expression techniques, safe storage, and handling. After surgery, Rachel felt well enough to breastfeed and was able to resume feeding her baby without interruption to their breastfeeding relationship. And one more thing I would comment about case number 2 about, lactating parents undergoing, surgeries in the hospital is that a lot of times, and I'm speaking from my experience at CHRISTUS St. Vincent, some people on the call might work at other hospitals. But when patients come into the emergency room, there is a list of questions that the nurses ask in triage. And one of them, it should be like, are you pregnant or breastfeeding? And they don't always catch the lactation question. And so recently when I was on with one of our residents, we had a patient that did come in with a surgical need, and the nurse in the triage area did not check that the patient was lactating, and it was actually caught once the patient came to the floor, about 24 hours later. So it is definitely important for us to, when we're rounding in the hospital to double check that, if it's a person that was admitted, the night before or something like that. Case number 3. Casey is a first-time parent who presents to urgent care with enlarged, full, and painful breasts accompanied by fever and flu-like symptoms for greater than 24 hours. She has an overlying cellulitis on her breast. She reports exclusively breastfeeding her 10-month-old. Recently, she returned to work and struggles to pump regularly due to limited opportunities, missing several pumping sessions. Casey reports painful latching and is worried about feeding her baby milk during mastitis. She's also worried about maintaining her milk supply now that she is back at work. What steps should Casey take to manage mastitis while continuing to breastfeed safely, maintaining milk supply, and protecting her baby's health? And again, you can put your answer in the chat or unmute yourself.
She should give me consent to call her work and tell them that she is allowed. She shouldn't have limited opportunities. Because that's really the issue.
Yeah.
So definitely would say she's okay to continue expressing. In fact, it's encouraged. Warm compresses are helpful. And I would give her antibiotics.
Yeah, that's one of the main questions I have for you guys. Would you give her antibiotics, and why would you give her antibiotics in this situation versus another situation?
Yeah, well, yeah, because she has cellulitis.
Yeah.
Fever.
Yeah.
Systemic symptoms.
Yeah. So I think this is a good example, like for primary care docs, we typically are taught in medical school, like, it's because it's a very like straightforward board question that the person if the person has mastitis, they get antibiotics, and there's those classic antibiotics that you always know to answer on your test. And I'm not going to say them because I have another question about this later, but the newer research and literature does show that mastitis is more of a spectrum, so not just a single disease. And so remember that mastitis really is a range from the initial like inflammation, just like the ductal narrowing of the breast, to inflammation, to then like an actual bacterial infection, which would be shown with fever and symptoms for over 24 hours and or a cellulitis, and then it can progress to abscess, in the worst form. And so we really want to encourage providers that you should always start conservatively. So If the person does not have an overlying cellulitis and the person does not have, fever or systemic symptoms, and it's very early on in the course, this is when you can really start conservative treatment safely, just with ice and NSAIDs for pain and inflammation, and then continuing to feed on demand. What will you say if Casey asks you in your visit if she should pump extra? Does she need to pump to get the infection out? And does she need to do it frequently or more frequently?
The more she pumps, the more milk she's gonna make.
She needs to pump because there's a status too. When you cannot pump or breastfeed in your routine, it's gonna cause a status in your ducts. So also it can cause mastitis too. So you need to relieve the duct and you need to pump. So it relieves.
But if she pumps more than the baby is able to take, then she's gonna be doing that for the rest of her time breastfeeding, because if you make more, like if you give out more milk, then you're gonna make more, and she's gonna get milk.
But the milk doesn't cause this mastitis. The reason it's status there is not pumping out the milk from the duct.
Anybody want to be the tiebreaker? One is saying on demand, don't pump more, and another person is saying pump more. Anyone want to be the tiebreaker?
I have a comment.
Yeah.
Would it depend on the mother's goals? Because if maybe she's returning back to work, she's okay with, breastfeeding for 10 months and, feels like she's done, then she can be done. Or if she wants to continue, that it would depend what she would want to do.
I love that, Amanda. I feel like it's so important every time we have a patient coming in to see us with, lactation concerns, that we should always be starting the conversation with, what are your goals, right? And so perhaps, her mentioning, I'm really concerned about maintaining milk supply. Perhaps that's her kind of way of opening the door to that conversation that maybe she wants to have with us. Thanks for sharing that. I completely agree. Anyone else?
Was a tiebreaker answer.
No pumping.
No pumping?
No pumping.
Yeah, just a regular, like you said, Amanda, just on demand. Yeah, just keep breastfeeding. Yeah, that's right. Yeah.
So this was updated, I believe, I forget what year it is. Monica probably knows better than me. There was a new protocol from the Academy of Breastfeeding Medicine that came out, and I think it might have been last year, but it might have been 2 years ago, that talks about, you can go to the next slide, that talks about feeding on demand. So it used to be that we were giving patients recommendations that if they had a mastitis, their breast was clogged and they needed to pump more to get the clog out. But we know that that's not actually the case based on newer evidence. And so it is recommended to just continue to feed on demand and to avoid overpumping, because as Daniel said, that does actually, if you're overpumping, it will stimulate more breast milk production, and that could even exacerbate the problem a little bit. So we want to make sure that we're kind of striking that balance. Anyone else have comments on that? And then in general, and I think somebody already mentioned this, but with mastitis, it is fine to continue breastfeeding throughout. Next slide. So Casey learned that mastitis often begins as inflammation, but can progress to bacterial infection, especially with persistent fever and cellulitis. Because her symptoms had lasted more than 24 hours, she had signs of bacterial mastitis, Casey was prescribed an appropriate antibiotic, dicloxacillin or cephalexin, while continuing to breastfeed safely. She was advised to use conservative measures, ice, NSAIDs, and physiological breastfeeding while avoiding aggressive pumping and deep massage. Casey felt relieved to know her milk was safe for her baby and that antibiotics would not require her to stop breastfeeding. To support her return to work, she created a realistic pumping plan. With these strategies and treatment, her symptoms improved and she maintained her breastfeeding relationship while feeling confident about her baby's health. So I do have three. I did want to mention that for the family medicine boards, you will have at least one question about lactation when you take the boards. And so these next three slides are the multiple choice questions that were actually taken from in training exams. And so it's 1:23. I want to make sure we have time if people have additional questions. So perhaps I'll stop here and ask if people have additional questions, and maybe we'll skip these three questions.
I'd also like to note that back to what Dr. Koffler said, that you don't have to have all the answers. And so keep in mind that lactation care providers are the experts in lactation. And we are constantly studying and learning around human milk production. That's our area of expertise. So whenever in doubt, there is a resource on the New Mexico Breastfeeding Task Force webpage for lactation care providers, so you can find local lactation care providers near your area. We also have resources as far as lactation support groups and other resources around lactation for parents that you can refer your clients to. So don't feel like you have to have all these answers or know all of it on your own. This really is a partnership.
Thank you.
Anybody have any questions?
A patient wanting to express colostrum in the prenatal period, and they're dead set on doing that, how would you advise them to do so safely?
Can you repeat that one more time? I could not hear.
In a patient that is wanting to save colostrum, how would you advise them to do it safely?
Pre-delivery or post-delivery?
Pre.
Good question. So technically, ACOG doesn't have any official guidelines on it. But there is no evidence to show that expressing colostrum prior to delivery will cause cause contractions or cause the patient to go into labor early, as long as we do recommend patients wait until they're around, I think, 38 weeks to start doing that. Is that kind of where you were going at?
Yeah.
Monica, do you have any comments on that about colostrum prior to delivery?
I think this is an opportunity for parents to also practice hand expression. That's a really great tool that parents can have at their disposal once baby arrives. And so learning how to hand express can help them in the long run if they're wishing to do that. And to Dr. Elizabeth's point, there is no evidence that is contradictive towards the end of the pregnancy.
May I ask a question? Hi, I'm Crystal. I'm a fourth year medical student. I was just wondering about a common thing that I hear for my patients to say about breastfeeding, and my patients would say that they don't want to breastfeed because then the baby will be too attached to the parent, and the baby will cry way too much, and then if the parents need to go back to work eventually, it will be too hard to go through separating, I guess. And so could you speak on what we might be able to tell patients about concerns about being too attached to the child?
I'll let you answer first, and then I have my answer.
So I guess the thing I typically say, and my patients have asked me that as well, there's so many different ways I think that like families can bond with their baby. And so I think that's a really great opportunity to talk about how if you are the lactating parent, about the ability to really bring your village around you to help you with other ways that people care for the baby and how other parts of the family who are not the lactating parent can bond with the baby in other ways.
Yes, I think reminding parents that also every child is different, right? And so sometimes they had a different experience with the first, and they're thinking that's going to have the same experience with this one, and that ultimately re-educating on the continuing benefits of breastfeeding and what are their ultimate goals, because sometimes just reminding them of the benefits of human milk feeding helps them to make that decision for themselves. And many of the patients I would care for, first of all, it breaks my heart to know that we live in this society that parents have to make those decisions. And that's why we continue to advocate for like family paid leave and all of those other pieces. But living in this situation, reminding them that when they go to daycare, there's a higher safety net when parents continue to provide human milk feeding because the babies tend to be healthier and tend to recover a lot faster. And so parents see, yes, there's a downfall to it, but also a benefit that and helps them to make their own decisions.
Thank you both very much. That's very helpful.
Get my blanket.
And I think we are on time, so I want to check with our hosts first to see if we can keep going or if we actually have to stop now.
Yeah, so it's just that time. So if people need to log off, of course, being respectful of that. And if there are any other questions, we can close out with that.
Thank you, everyone.
Thank you, everyone, for being here.
Yes, thank you so much, Dr. Koffler and Monica. We really really, 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 really appreciate your presentation today on such an important topic. Thank you so much, Dr. Koffler and Monica. We really appreciate your presentation today on such an important topic. Appreciate your presentation today on such an important topic.